All right, this is part 2 of our workshop on January 5th, concentrating on the lower limb.
Ta-da! So, the table I want to point out to you in the handout is an overview on when it's safe and when it's not. Okay, when it's safe and when it's not. Most of the stuff we deal with is chronic, it's old. Occasionally though, anybody can fall, sprain their ankle, something. And so you wanna know what to do to help that client with that. So when there is an acute injury, and you can extrapolate this to an illness, and the difference is injury involves external types of tissue damage, like a sprain or a strain or a bump or a bruise or a car accident or that sort of thing. And an illness is more systemic. It involves things like, COVID. You can have your infection-based illnesses. And you can also have autoimmune, the whole autoimmune class. But it affects more of the body, and that can also be acute, but it can also become chronic. So, in the acute phase, if you decide you're going to do anything at all, you don't do much. So, if I had just fallen and sprained my ankle, and it was real localized like that, you're not going to touch the ankle. Because the acute phase is doing what it's supposed to do. You don't even address the swelling. And there is controversy over whether you put ice on it, even. So, things change. And we'll use this as an example of what changes. For years and years and years and years and years, the treatment for an acute injury was to put ice on it to control the inflammation and the swelling. Finally, people realized that the inflammatory process in the acute phase is good, and it supports a normal healing process. Bye, sweetheart. I love you. Your mask is beautiful. You gonna go see your brother Lucas now? Okay. What?
Speak louder, honey. And my daddy too.
And your daddy too. All right.
Okay.
I'm glad you visited me. Yeah.
You want to give Grandma a hug?
That's hard.
I should bring my juice and milk.
Oh, all right. You can get juice in your milk. Are you gonna take it?
Yeah.
All right. Ta-da.
Have a good day, everyone. Bye.
Now it's been rice, rest, ice, compression, elevation, and then it was price, plus rice, protection plus, and then it was police. Do you remember what police?
Police is protect, optimal loading. So the thing that gets confusing with it is the O and L are together. So let me do it quick. But I'll just verbalize it. But P for protected. So make sure that can be a wrapping or a bracing or just being careful. Optimal loading, meaning you can move it, and most especially if you can get into gravity and load it within the range of it still feeling safe. It's like the way that they grade sprains. Okay, grade 1, you have a hurty thing, but you can walk around okay. Doesn't offset your gait. Grade 2 offsets your gait. You have a limp. Grade 3, you can't stand on it without it hurting. So optimal loading for a grade 2, since they can stand and be okay but can't walk, I wouldn't have them walk, I'd have them stand and do some little bends. That'd be optimal loading. So if I was gonna protect it, maybe I wrap it in an ACE bandage. Optimal loading, I have them stand, that doesn't hurt to do, okay. They can do some little knee and ankle bends. And then the rest is just like the rest. After that, you protect it, you optimally load it. The protection helps you with when they load it, they can't move silly and hurt themselves more. So another example would be if it's a knee injury, maybe they brace, then do the optimal loading because it's additionally protected. And then the rest is ice. It's just ice again.
Yeah,
So
ice color.
ice,
Compression.
compression, elevation.
Alright, so then they changed it into meat. Which is, I can't remember what meat.
Movement,
Movement,
elevation,
elevation, analgesic,
analgesic.
and therapeutics.
I think that's right.
Therapeutics means ultrasound, stuff like that. Okay.
They've been finding, the key thing you'll notice here is there's a movement piece attached. Instead of just icing, compressing, elevating, there's a movement piece attached. They want to decrease scar tissue or densification of tissue. They want you to heal while maintaining mobility. That's all it comes down to. They've learned the same thing with how it's changed with replacement-based surgeries. As soon as you wake up, they get you moving. Why? Because they found when people heal while they're doing movement, they don't develop as much scar tissue or densified tissue. That's all it is.
So, the key thing here with the meat is they took the ice out. And that was because there's a recognition that the inflammatory process in the initial stages of healing is important. So ice would interfere with inflammation. Ice can't penetrate deep enough to interfere with healing-based inflammation.
But it's a great analgesic.
But it's right, it's a great painkiller.
Doesn't fix it. You can't not feel the cold. Your body registers and pays attention to the cold more than the other stuff. So you're distracted.
All right. So, so what's really bad is taking an analgesic that's an anti-inflammatory. So, Tylenol does not have anti-inflammatory qualities to it, but it will deal with the pain. But aspirin and ibuprofen and Aleve and those kinds of things have anti-inflammatory qualities to it, and they should be avoided in the acute and subacute healing phase. But they're usually prescribed for pain. So, I am an ice fan for pain control. Alternating hot and cold is good. Start with heat, then put the cold, then put the hot, then put the cold, end with cold. Start with heat, end with cold. So that's hydrotherapy and thermotherapy. So that comes in with some of this kind of stuff. In the subacute phase, early, this is about 5 to 7 days into it, then you can start looking at managing some edema if it's still there. So, fancy name is lymphatic drainage, whatever. Fluid movement. It's not even lip, it's interstitial fluid. Interstitial fluid is the swelling. So now we've got the wrong name on the wrong method, but that's embedded. I don't know how many of those of you that work with me have heard, I want a lymphatic massage, or I want a flush, or who's heard of that one? That's shown up on stuff? Yeah, well then,
But lymphatic drainage based techniques help move edema.
Mm-hmm.
So you use the technique to move the fluid regardless of what the fluid might be. If it's superficial just under the skin, you move the skin back and forth and use gravity and things like that to move the fluid out from that subcutaneous tissue. There you go.
And it's, the way it's taught is usually pretty light, so it's not gonna hurt anything. Okay. As the person starts to be able to load it a little bit better, then you wanna make sure that, I still haven't touched the area except maybe for some light lymphedema, you know, a light lymphatic-y type thing. If I'm limping, or if I'm holding my shoulder still, or whatever it is, there's always a balance of stability and mobility. So if I'm holding something still, something around it's gotta move more. Or something is gonna get stiff because it's trying to hold something still. So that can become habituated. So you can mess with that stiffness a little bit, maybe increase some of the movement a little bit in other areas of the body other than the area that is injured. Still haven't touched the injured area. But if I'm limping, I'm gonna have issues on the other side. I'm gonna be using one area more while the other one is held more stiff. And during the remodeling phase, we're 6 weeks in now, 6 weeks into this, they should be starting to return to normal. So if there's an area that is still a little stiff, I can start bringing in some methods that can make that more pliable. Whether you call that connective tissue work or myofascial work or whatever, I don't know. But it's using enough mechanical force so the tissue changes shape. And you're not just moving on the surface of the tissue. This chart down here gives you some idea based on the evidence-informed outcomes, which means research has indicated probably, not fact, but probably. So there's 4 of those. And what assessments you would do. So assessment involves trying to figure it out. How is it different? How has it changed? Is it functioning as well as it can? How do you compare it from one side to the other? That sort of thing. If you look, so that the 4 evidence-informed outcomes are relaxation, well-being, stress management, pain management, and mobility. If you look across there, pain management and mobility have the most assessments. And general well-being, relaxation, and stress management have fewer assessments. So if somebody's coming in for the experience of a massage, they're not going to want to stand there for an hour and a half while you perform every single assessment on them that you know. So you need to learn to pick and choose. Now, when you're learning, you have to learn them all. But when you get into actual practice with it, you will just do the ones that are most pertinent. Your most valuable assessment process is the full body general massage, where you sift around and move all of the tissue and move all of the joints in multiple positions. That is the foundation and the basis of your assessment. So manual methods, manual therapy, massage is a form of manual therapy, that don't assess the whole body in context, miss it. They miss the compensation. They miss the stuff that might be even perpetuating a pattern. So, and usually the general full body massage that moves every joint, shakes things, presses things, pulls things, will deal with it. It'll deal with the compensation. Especially if you're mindful when you're doing this. So if I'm mindful that an area feels a little boggy, like a water balloon, I might add in a little of that fluid movement idea. Or if I'm in an area where the person can point at it and say, that's the spot, I might apply a little bit more pressure there and have them move it back and forth, or apply the joint movement with it. Or if something feels kind of stuck or stiff, that's when I might stick a cup on it. Lift it up, pull it around, try to get things to slide a little bit better. I am not a fan of the scraping stuff. Just letting you know. I show you how to do it in the classes, but I don't know what it does other than something called counter irritation. So, have you ever put like an icy hat or something on an area that was sore? All right, that ointment stimulates a certain receptor in your skin, just like ice does, and your central nervous system has to process that. And so it doesn't pay as much attention to the angsty thing underneath the area. So it's like a mask. It masks it. Works great, especially in chronic stuff. It's not gonna go away probably. A person's gotta learn to live with it anyway. Using these counter irritation methods, and massage in general is a counter irritation method, applies a different sensory experience on top of something. If the person feels better and moves better for 24 to 48 hours, over time they're gonna do better. So, the main assessment that is brought into play for stress management is breathing assessment. And that's focusing on mobility of the torso. That's why we're going to focus on that when we get to that piece of the topic. As far as evidence is concerned for research, tons of it supporting relaxation, autonomic nervous system balance and down regulation from the fight or flight, stress, reduced stress indicators and everything that goes along with that. Good for pain management in general, not specific pain things. So in general, good for low back pain, but not because you worked on the low back. And if you did work on the low back, it's because you substituted a different sensory experience. You pushed on it, you pulled on it, you rubbed something on it, whatever. So all of the methods that are targeted to fix a painful spot are not necessarily supported by research. But general pain perception, ability to function better with pain, both local and systemic, general massage works really good for that. And if it is a spot they can touch or move, you want to also touch it and move it, so that they know that you understand that that's the spot. Functional mobility, the one that's most complex down there. Very little research supporting it. Very little. In fact, the current research is even challenging the idea of specific exercises. Like you had said, I think it was you, Heidi, massage is really good at taking stuff that is kind of short and stiff and making it longer and more pliable. But there also needs to be the tightening up or the exercising or the balancing it out. That's even under question. Okay, exercise is great. It doesn't matter what you do as long as you do something. Precise exercises for general well-being, probably not. Methods like yoga, Pilates, walking, swimming, non-performance demand, not trying to get better and better. Now, those are valuable. Strength and conditioning would be a short-term, temporary intervention as part of a rehabilitation. So, joint replacement. You would have a period of time when you would try to bring localized function back into play under the new normal, because it's never going to be the same as it was. Strength and conditioning exercises for performance demand, like a ballet dancer, for example, or something along those lines, are usually taking people out of normal function and will probably end up hurting them in the long run. Ta-da. So, Luke and I have spent a lot of time working with professional athletes. Not one of them got out of there without a permanent injury that'll plague them the rest of their life, of some type. So, you know, as we're looking at what we're going to do in general on this, we have to start to think about, you know, what are our realistic expectations. So I had one of my graduates who's currently working with the Lions, who had a person had an injury and then they had a surgery and then they went through their rehab to get it back to function, and they were still, the player was still angsty about it because it felt different. It didn't feel the way it had felt before, and kept asking, when is it going to be better? And the answer to that is that it is better, but it's different. It's not the way it was, and it never will be the way it was, but it doesn't mean it's broke. And that's the same type of awareness that people who have chronic pain of all types have to come to. And whatever set that chronic pain up. You know, was it an injury? You know, were they in a car accident, or did they have something that was work related or whatever? And there's no test, there's no MRI, no X-ray, no whatever that is showing that there is acute damage anywhere. They want it to feel like it did before, and it never will feel like it did before, because it's not like it was before, but it's not injured, and they're not going to hurt it, and they need to learn how to function anyway. That's hard. Anybody had any experience with that on your own, where you finally had to get to the point where you went, you know what? This is what it is now. Anybody got a story to tell or anything on that? Yes.
I had a partial tear to my left meniscus about 7 years ago in my left knee. So it clicks sometimes, or it gets sore sometimes, and it's never going to be the same, but I've learned with good stretching, I tried yoga, and when I feel like it might get out again, I put my knee brace on. That's my new normal.
Yep.
Like if I know if I want to do yoga, or if I want to go bowling, or if I want to work out and I'm using weights, I just know I have to put the knee brace on. most of the time I don't have to wear the knee brace, but there are some times and there's no shame. I just have to wear it.
Cause you've got an underlying instability that's not gonna get better
Right.
unless you did some, surgical intervention.
And I didn't need surgery, and maybe somewhere down the line I may have to have a partial to a full knee replacement, but right now I don't.
So, that's called, there's two terms now that are floating around in relation to that. One is pain science or pain science education, and the other is biopsychosocial model of care. So who's heard those two terms? Has anybody heard those?
one again.
Biopsychosocial.
Biopsychosocial model of care. And they basically are, how do you help people realize that they're okay, even though their function might be a little different?
A tagline I have used is trying to take the scary out of the pain. So you have to think from a little bit of an instinctual response that we all have. Pain means danger. The body is hardwired to trigger into that fight or flight sympathetic arousal in response to pain. So even like what Sandy was talking about with how do we explain what we do works? And it's all becoming, as we're able to get a better lens using research, we're finding that it's much more nebulous and ambiguous than ways people were giving a very precise explanation in the past. They were saying, I do this and it works in this very concrete way, but a lot of that was just associated with an accumulation of practical experience as opposed to more critical research. And we're finding now with the biopsychosocial model, for example, that frankly, it's also interconnected. We're best suited to look at it from a more full body, mind, health, social community kind of construct. It's all so interwoven. So pain perception, but the tough part with this is the more ambiguous it becomes, it feels like it's more complex because you don't have a very precise roadmap to follow anymore. You're stuck assessing each person and trying to just assume they each have their own unique story, their own unique way of adapting, and you're gonna try to assess the best you can and help them the best they can. And with biologic plausibility, that's where my head goes a lot. Assuming, okay, I don't know if massage does a great job with really retraining a muscle to know if it should be too concentric or too eccentric in its contraction. But I do know that when people, like any movement-based therapy that stood the test of time, like yoga, Pilates, Tai Chi, a lot of these like more ancient kind of disciplines, they incorporate full body movements in every range with a lot of breathing. Right? If you don't move your body regularly through full range, stuff tends to get stuck in those patterns. And so biologic plausibility is the body does a very good job of self-maintaining when everything can move properly. So getting venous blood back into the body, it uses muscle contractions and the pumping of the joints to do it because it's free energy. Body doesn't have a pump that's forcing the blood back up, it uses everything else to do it. But if somebody loses mobility in a limb, guess what? Now they're gonna not have that circulation effect anymore. So what do? I try to pretend, well, if they can't do it, I can do it. What's the number one thing they do for somebody with paralysis? They get them out of gravity and they move everything back and forth. As though it's walking. Let's say it's a leg. Okay, so what's the easiest thing I can do in massage? Sift through every layer, move it back and forth, and lots of joint movement. That'll accomplish an awful lot if I move every joint and think as best I can to work through every layer of tissue within the range of what is comfortable for the client.
And mimic normal. And in order to mimic normal, which is what Luke is talking about, you have to understand normal. So that's where the studies on anatomy and physiology come in. Is that you understand normal. You can't facilitate fluid movement in a biologically plausible, makes sense way if you don't understand how it normally functions. So fluid movement, all of them are pumps. So if I'm gonna try to facilitate fluid movement in the body, mimic normal, which doesn't hurt anybody if you mimic normal, then I need to have something that feels and looks like a pump. And what's a pump? You know? So it's, you know, think of how you would pump an old pump at a campground or something. So that's a really important concept. So if the connective tissue is stiff, the person feels stiff, you know, they're always doing this kind of thing. You know, you've seen them, right? I do. Stiff. Have you ever had on some clothes that just didn't fit right and were too tight or something? How did you treat that? What did you do?
Take them off.
Take them off, which is probably not okay. If it's your skin, superficial fascia.
Try and stretch it in different directions.
You try to get it to, all right? And most of that is some movement, a little bit of elongation, stretching, and pulling. All right, have you ever had a spot that just, you know, it just felt like it was stuck and stiff and kind of mired down? Have you ever just kind of got a hold of that spot and pressed on it and kind of twisted it around? And all right, now there's names for all this stuff. You can call it myofascial release or lymphatic drain or I don't know. The list goes on and on. But what I want you to be able to do is to back it down to pushes and pulls. And a combined push and pull would be a twist, push and a pull, and how can I do that in a sequence that mimics normal? So, what goes wrong in the lower limb? What do people talk about? Think those of you that have been around for a while, what do they come in and they tell you when they're from their waist down?
Yeah, bum knee.
Got a bum knee. All
What are
right.
some foot-based things you tend to hear? There we go. Plantar fasciitis.
Bum knee.
Bum knee.
Hips are tight.
My calves cramp all the time.
Okay. Cramps.
Cramping, yeah.
What was the other one? Hips tight, hips are tight.
Charlie horse.
Charlie horse. How about aches? Just aches.
Gives out. Like a knee gives out.
Gives out.
Feels loose.
Instability.
Bad arthritis.
Okay.
I was
Joint.
waiting for arthritis, yeah.
Joint. Degeneration. All right. So now each one of those things probably has a medical term for it. And so, you know, they might even come in and say that. I had arthritis in my knee that has now progressed to arthrosis with 3/4 degeneration of the hyaline cartilage, and I am preparing for a resurfacing procedure. Or they're gonna say they got a bum knee. And what do they want?
Relief.
They want some sort of relief. They want it to feel different. All right, so that's our goal. So if we're gonna do any of this, then we have to start out with knowing what this is. What is a lower limb? What is the purpose of it? So what is the purpose of our lower limb?
Support.
Stability.
So one of them is stability, so we can stand up. We can stand up. Okay, good job.
Then what do you gotta do once you stood up?
You gotta move, walkability.
All right, so now you gotta walk. A big part of the lower limb is mobility or walking, isn't it? So if people come in and they have some sort of issue, it's likely that it's gonna have something to do, if we're talking about the lower limb, it's got something to do with being able to stand up or lay down and get standing up, or sit down and get standing up, stay standing up, and moving.
Without expending all the energy.
Well, and then that movement can just be daily life activity movement, which is being able to, you know, go to the grocery store and drive your car and all that kind of stuff, or it can be performance-based movement, like a dancer or a gymnast or whatever. Performance-based movement is always beyond normal. So it's never normal. That's one of the things we have to consider when we're dealing with a performance-based client. Whether they're, again, a gymnast or an athlete or a dancer or anything like that. They're asking their body to do something that it was not really designed to do. So that's gonna strain all the normal too. And so, if we're gonna concentrate on the lower limb, then we need to pay attention to the structures that are involved in stability and mobility.
And relating two structures with some quick terminology, especially for the newbies. Axial skeleton, spine and ribs, skull, then appendicular, your appendages. So your scapulas or shoulder blades to your arms, or your pelvis, your ilium, to your leg. So we are talking about part of the embedded in this, the skeletal component is the appendicular skeleton. So the appendicular components are based more about mobility, and the axial skeleton, meaning the spine, we'll come back to that one later, but I'm just reinforcing for them that we're thinking the pelvis down to the foot, or the scapula out to the hand.
So where there are usually lots of ugly stuff is where the limb joins the torso. Because it's all the different ways, all the different movements of the structure, all the different ligaments and tendons and connective tissue and